Good morning, doctor. The following patient presents at your clinic today. This is an 11-year-old male cat. He's presented with lethargy and polydipsia, and 1 month ago his PCV was measured at 38%. Please take a look at these labs and make sure to pause for a few minutes and write down as much as you can about which numbers seem abnormal to you, which of them are the most important, and what might be causing them. I hope that you're ready. Let's go over the lab diagnostics for this patient. Starting with the hematology, we can see that packed cell volume, red blood cell number, and hemoglobin are all down. Leads us to the immediate conclusion that this cat is anemic. We see that mean corpuscular volume is actually up. This is suggesting a regenerative anemia, because red blood cells that are released slightly early tend to be larger in size, and if we have early release of red blood cells, this shows that our anemia is regenerative. Our reticulocyte number is high, which confirms that this is a regenerative anemia. Whenever reticulocytes are over 60,000, this confirms that we have a regenerative anemia. Now, what do we know about regenerative anemias? These can be due to blood loss or due to blood destruction. And we know for sure that it is not bone marrow dysfunction, because in that case we would have a non-regenerative anemia, because if the bone marrow isn't working, new blood cells will not be produced. We see that nucleated red blood cells are also elevated, which also confirms that there is early bone marrow release, because the eviction of the nucleus is one of the last things that happens before a red blood cell is matured. So in this case, the bone marrow is hurrying to get these red blood cells out there to make up for the anemia, and that's what we call a regenerative anemia. Then we notice something really interesting on the blood smear examination down here, which is Mycoplasma haemophilus present in high numbers on our red blood cells. Mycoplasma haemophilus actually explains the regenerative anemia, because the presence of this pathogen on the red blood cells causes the immune system to destroy the red blood cells. So this induces immune-mediated hemolytic anemia. And so we have found our cause for our regenerative anemia, which is in this case blood destruction due to Mycoplasma haemophilus on the red blood cells. So this case so far is really interesting, but there are some more things going on, so let's keep on looking. The monocytosis combined with immature neutrophils suggest a inflammatory leukogram. The lymphopenia, on the other hand, could be indicative of an inflammatory or a stress leukogram. And all of this is lining up pretty well with the fact that we have a Mycoplasma haemophilus infection in this patient. Let's continue looking at our biochemistry. Serum glucose is moderately high. This might be due to stress, the release of glucocorticoids, but it could also be due to diabetes mellitus. Blood urea nitrogen and creatinine are both elevated, and if we look at the urine-specific gravity down here, we see that this is lower than it should be, 1.020. It should be around 1.030. Combining these facts together, elevated blood urea nitrogen plus creatinine plus a low urine specific gravity indicates renal azotemia. So the kidneys are struggling to concentrate because we have a low urine specific gravity, and we can see this in the blood urea nitrogen and creatine values. The phosphorus is mildly increased, which actually checks out. This can be a consequence of a decreased glomerular filtration rate, which is again compatible with the fact that the kidneys are struggling in our patient. Cholesterol is also increased moderately, which could be due to metabolic disorders associated with diabetes mellitus. Total CO2 is decreased, showing us that there is a metabolic acidosis in our patient. And lastly, the osmolality is increased, and this is most likely due to the hyperglycemia combined with the high blood urea nitrogen. Looking at the urinalysis, we have already noted the low urine specific gravity indicating the kidney is struggling. And we now see that there's also glucosuria present. This is showing us that the renal threshold for glucose has been exceeded. Putting all the facts of this case together, the following picture emerges. Our patient is a diabetic who is being badly managed for his diabetes mellitus. The diabetes mellitus predisposed our patient to an immunocompromised state, which allowed Mycoplasma haemophilus to take over. Mycoplasma haemophilus binds to the red blood cells, and this leads to immune-mediated hemolytic anemia. The immune system destroys the red blood cells. For this reason, our packed cell volume is incredibly low, and our patient was presented to us in an anemic state. When there is strong hemolysis, this can be damaging to the kidneys, which is why we have renal azotemia. And because of the unmanaged or badly managed diabetes mellitus, there's also metabolic acidosis. I hope you enjoyed this case, and see you next time.